looking at acid-base disorders, this is basically an introductory lecture. So I'll try to keep it very simple. Then you'll need to go and read up more about this. So acid-base disorders.
Doctor, do I have the permission to record the class?
Please do.
Thank you.
So the objective.
Recording in progress.
What do you need to know by the end of this lecture? Number one, you need to define what an acid is, what a base is, what is pH, and what is normal pH. Then you need to understand what normally occurs for acid-base homeostasis. What are the mechanisms which keep your pH within normal range? After that, you need to understand compensatory mechanisms. Yeah, what do we mean by compensation? Then we'll dive into the acid-base abnormalities. There are 4 of them that we shall look at in greater details. As we're looking at one of them, that is metabolic acidosis, we look at the concept of the anion gap. And then the last part of the lecture, I'll take you through a brief guide on how to interpret the blood gas analysis. So this whole lecture is extremely important for you guys because acid-base abnormalities are quite common. So we start off by the definitions. This is basically from your high school chemistry. An acid is any substance that can yield a hydrogen ion when dissolved in water. So basically it leads to release of a proton or a hydrogen ion. A base, on the other hand, is a substance that can yield hydroxyl ions. So basically it's able to accept protons or hydrogen ions. pH, what is pH? It's basically the negative log of the hydrogen ion concentration within the body. And it is given by the formula that pH is equal to pK. pK is basically a dissociation constant. It is a constant at 6.1. So you add 6.1 plus the log of the concentration of base divided by the concentration of acid. So that is how pH is calculated. And basically it represents the hydrogen ion concentration. So why do we need to maintain pH within a normal level? So let's start off with the normal pH. So normal pH, the range is 7.35 to 7.45. So if I give you a BGA within the word, at the very least, I expect you to say whether the pH is normal or not. So normal pH is 7.35 to 7.45. So acid-base balance now tries to maintain that pH stable within that range because it is the physiologic pH necessary to prevent enzyme inactivation and denaturing. So back to your physiology. This is a graph of enzyme activity versus the pH. You can see that enzyme activity is maximal at a pH of about 7.4, but you allow for a range of between 7.35 to about 7.45. Once you get beyond that, this now is the alkalotic range, you get denaturation of your enzymes. If you are below 7.35, now you're acidotic. Again, you get enzyme inactivation and denaturation. So that if you go beyond 7.35 to 7.45, what are the clinical consequences? You'll have consequences in your cardiovascular system where you've got poor vascular tone, you can get myocardial pump failure and increased risk of arrhythmias. In the musculoskeletal system, you get skeletal muscle weakness, you can get electrolyte abnormalities, you can get impaired cellular respiration, and eventually abnormalities of your acids and base balance can lead to coma, delirium, and even death. So it's extremely important to understand how you can return pH to normal in case it is deranged. So let's take a step back and try to figure out where exactly is the acid coming from within the human body that you actually need to regulate. So physiologic production occurs from metabolism either of carbohydrates or fats. So when you metabolize carbohydrates normally or fats, there will be production of CO2, and CO2 is a volatile acid. Metabolism of proteins leads to production of sulfuric acid. Metabolism of phospholipids now leads to production of phosphoric acids. All these are non-volatile acids. So the good thing with CO2, it is volatile, so it can be blown off by the lungs, okay? But these other non-volatile acids will require buffering. So eventually, net acid production from your metabolism within the body should equal net acid elimination to maintain your pH within normal. So basically, it's a three-stage process. You need to remember that acid is produced as a consequence of normal metabolism of your carbohydrates, your proteins, and your phospholipids. It's then transported via blood, and the net acid production should equal net acid elimination through the lungs and through the kidneys. So through the lungs, we're talking about volatile acids like CO2, and then through the kidneys, that is what helps you to actually eliminate the non-volatile acids. So back to our normal pH, we've said it's about 7.4, and that actually corresponds to a hydrogen ion concentration of about 40 nanomoles per liter. So it's important to remember that the relationship between the hydrogen ion concentration and the pH is inverse. So when you've got an increase in hydrogen concentration, that leads to acidosis. And when you are acidotic, the pH is low. Okay, so a pH of 7.2, for example, is low, and it means that you've got a high hydrogen ion concentration. So that relationship is inverse. So when we have a pH less than 7.35, we call that acidosis, and a pH more than 7.45 is alkalosis. We go back to our formula for calculating pH. We said it is equal to pKa plus the log of the bicarbonate divided by the concentration of the CO2, okay? So basically your pH is directly proportional to the bicarbonate. So if the bicarbonate is high, the pH is also high, what we're calling alkalosis, okay? But pH is inversely proportional to your CO2. So if your CO2, remember it's a volatile acid, if the CO2 is high, the pH will be low. It will be in the acidotic range, okay? So this is just a mnemonic for you to remember. Acidity is equal to bicarbonate over carbon dioxide. A equals B over CD. So just remember that it will be directly proportional. pH is directly proportional to bicarb, but inversely proportional to your acids. Next, we move on to look at greater detail at how the body regulates the pH. So there are two lines of defenses against pH shift. The first line will be your chemical buffer system. Then the second line are your physiological buffers. So within the chemical buffer system, one of the most important buffer systems will be your bicarbonate, okay? So remember your bicarbonate is negatively charged and it's able to actually buffer your positively charged hydrogen ions, yeah? Second line of defense will be your physiological buffers. So remember we've said that CO2 is a volatile acid. So the lungs become very important in CO2 excretion, okay? So that helps to regulate pH. Number two will be your kidneys. I guess this is why this is being covered in your kidney lectures. Renal mechanisms are going to be extremely important for excretion of hydrogen, excessive hydrogen ions. So we look at all these in greater detail. So let's start off with the first line of defense, which are your blood and tissue buffers. These are basically, when you talk about acid-base homeostasis, you're basically talking about the mechanisms that maintain the pH between 7.35 and 7.45. So starting off with the chemical buffers, one of the most important systems here will be your bicarbonate system. So this is a very familiar equation, I'm sure. So bicarb is able to bind to hydrogen and form carbonic acid. Under the influence of carbonic anhydrase, that carbonic acid is then converted to CO2 plus water, okay? So you can see that the bicarbonate has buffered that hydrogen, and the end product is actually CO2 that you can now remove through the lungs or blow out through the lungs, okay? So this becomes a very important buffer system because you have a relatively high concentration of bicarbonate within the ECF, So it is about a range of between 22 to 28. Some texts will say between 22 and 26. So it depends on what you're reading. But there's a relatively high concentration of bicarbonate that is available to buffer excessive hydrogen ions. It's also an important system because the key components are under physiologic control. So it works together, this chemical buffer system works together with your physiologic control mechanisms. So CO2 is able to be excreted by the lungs, and the bicarbonate can be reabsorbed by the kidneys, okay? So you can actually reabsorb more bicarbonate as required for buffering of excessive hydrogen. Next line of defense, we've said, is the physiologic systems. We're talking about the lungs and the kidneys. So let's start off with the lungs. So when you have got acid-base disturbances, you can have respiratory compensation to try and bring the pH back to normal. So what is the advantage of this particular system? The respiratory compensation can occur rapidly, okay? So it's very easy for you to stimulate ventilation and blow off more CO2. So how does this happen exactly? If you've got acid accumulation within the body, these pH changes will be detected by the brainstem, okay? So the brainstem detects that the pH now is 7.2. It begins to stimulate the ventilatory drive. So you start hyperventilating, and so you're clearing out or blowing out CO2. So that reduces the partial pressure of carbon dioxide, which remember is one of the volatile acids. So when you reduce that, you now start to get the pH back to normal. So it moves from the 7.2 and can go back to the 7.35, okay? The opposite will occur with alkalosis. So with alkalosis, the pH now is high. It's beyond 7.45, okay? So what happens is that, again, the brainstem will sense this. It will inhibit ventilation so that you're retaining CO2, okay? So that then brings your pH back to within the normal range. However, it's important to note that for this second part, it has a limited capacity to change pH, because as you reduce the ventilation, okay, normal ventilation maybe is around 14. By the time you reduce it to maybe 8, you start getting hypoxic, okay? So of course the brainstem again senses that, and so it will actually provide an alternative stimulus to increase the ventilation again. So this one, it doesn't work as well as for the first type where you have got acid accumulation. I hope that is clear. Yeah, you can only reduce your ventilation so much. Yeah, once you get too much of the hypoventilation, you now get hypoxic, which then re-stimulates the respiratory drive. The next compensatory mechanism will be your kidneys. So renal regulation of acid-base balance occurs at 2 levels of the kidney. The first part is the proximal tubule, and then there is also acid-base regulation in the distal nephron. So starting off with the proximal tubule, the proximal tubule is able to reabsorb about 85% of the filtered bicarbonate ions, okay? And this whole process is dependent on carbonic anhydrase. So this is a picture or a cartoon of the proximal renal tubular cell, again, which looks very familiar even from your physiology and pharmacology lectures. So basically, this is the luminal side, and this is the blood side, okay? So how exactly is the filtered bicarbonate being reabsorbed? So the filtered bicarbonate has been filtered at the glomerulus. It's within the lumen of it, or within the urine, okay? How do you get it back into the body? Basically, it will combine with a hydrogen ion. It forms your carbonic acid. And the carbonic anhydrase, this is then converted to water and CO2. Now, CO2 is freely permeable through the cell membrane, so it's able to diffuse very freely back into the cell, then combines with water that has been formed from metabolism, cellular metabolism processes. So that then forms your carbonic anhydrase, carbonic acid, which again under carbonic anhydrase splits to a hydrogen ion and a bicarbonate. Okay, so it's a very clever way of getting this bicarbonate back into the cell, and then now it's reabsorbed back into the bloodstream. So that is how the kidneys are able to reabsorb bicarbonate to help with buffering of any excessive acid. What happens in the distal nephron segments? Here now, the distal nephrons are responsible for acid excretion, okay? So for the proximal, it's more of bicarbonate reabsorption. But when you get to the distal segments, we're now talking about acid excretion, okay? And this mainly occurs within the alpha intercalated cells of the collecting duct, okay? So acid will be secreted into the lumen by a hydrogen ATPase, so it requires the use of energy. It secretes hydrogen into the lumen or where the urine is, okay? Such that that hydrogen can then be excreted through urine. Finally, in terms of the buffer systems, you've got urinary buffers. Importantly here, you've got phosphate and ammonia, okay? So phosphate that is within the urine, it's already been filtered, it's in the urine, is able to bind to hydrogen ions and form your phosphoric acid. And then now this is excreted in the urine with sodium. Similarly, ammonia is actually able to bind to a hydrogen ion and form ammonium, which then becomes trapped within the luminal fluid or within the urine and is then excreted with chloride ions. Okay, so these two mechanisms are actually able to remove approximately 1 millimole per day of the hydrogen ions. Now, this is actually equal to how much you produce from metabolism, okay? So every day you're producing about 1 millimole per kg of non-volatile acids from metabolism of dietary proteins. So you don't become acidotic because your kidneys are able to excrete that acid. So usually your urine pH, it's important to remember with all this secretion of hydrogen ions, urine pH is usually typically in the acidic range rather, okay? So urine pH is typically between 5 and 6, okay? And that helps to maintain the plasma pH of 7.4 despite all the acid you are producing in a day. So that was the introductory part. We move on now to look at the acid-base disturbances, okay? So in a nutshell, we've said, if you've got accumulation of acids or excessive loss of bases, so you don't have enough bases to buffer the acids, so the acids continue to accumulate, the pH will drop, and now we call you acidotic, okay? If, on the other hand, you've got excessive loss of acids, for example, you're vomiting a lot of the HCl, or you're accumulating too much of the bases, this leads to a decreased concentration of the hydrogen ion. Your pH will rise, and now we call this alkalosis. So this is an important slide that you need to memorize because this forms the basis of you being able to interpret your blood gas analysis. So normal pH, 7.35 to 7.45. If you're less than 7.35, acidosis. More than 7.45, alkalosis. Next thing you must know is the normal partial pressure of carbon dioxide. So normal PCO2 is between 35 and 45 millimeters of mercury, okay? The patient who has got respiratory failure, so they're not able to blow out that CO2, will have retention of CO2. So it will be more than 45 millimeters of mercury. So if you've got more than 45 millimeters of mercury, you now start becoming acidotic, so the pH is low, okay? For the patient who has got hyperventilation, I'm sure you've seen patients who are very anxious, they begin to hyperventilate. This also happens to you when you're coming in for orals. Hyperventilation, you're blowing off a lot of CO2, okay? So the partial pressure of CO2 drops to less than 35, okay? So there's less acid within the body, so you become alkalotic. Sawa. So the pH is high, so you've got an alkalosis. And if the primary issue that is driving that is a respiratory issue, such that you're losing too much CO2, we call that respiratory alkalosis. Finally, we look at the normal bicarbonate. Again, this should be on your fingertips. Normal bicarbonate is between 22 and 26 milliequivalents per liter, okay? So if your bicarbonate is low, remember this is what is used to buffer your acids, okay? So if your bicarbonate is low, we say that now you've got a metabolic acidosis, okay? Bicarb is low and the pH is also low. If you're retaining bicarbonate or you've given the patient too much alkali containing solutions, bicarbonate can go to more than 26, okay? So you're retaining a lot of base, so your pH goes high, yeah? So that is what we call a metabolic alkalosis. So important to memorize normal pH, normal PCO2, and normal bicarbonate levels. So when you've got an acid-base imbalance, the body's response to that is called compensation. So your body does not just sit back and just let you go into acidosis or alkalosis. It tries to correct that, and that is what we call compensation. So compensation may be either complete or partial. So if your body is able to bring back the pH back to normal, we call that complete compensation. However, if the pH, your body is trying, but the pH is still outside normal, we call that partial compensation. And then now there, you require now the doctor to help your body. Sawa sawa. So compensation can either be complete, where your body takes care of the issue by itself and normalizes the pH, or it can be partial. So it is trying to compensate, but pH is still outside the normal. So let's look at some of the compensatory mechanisms. We go back again. You're going to see this formula over and over today. Yeah? So pH directly proportional to bicarbonate, but inversely proportional to CO2. So when the problem is primarily a bicarbonate issue, bicarbonate, remember, is mainly controlled by the kidney. If the problem you see on the BGA is mostly the bicarbonate is in the same direction as the pH change, we're talking about metabolic disorders, okay? But if the problem is specifically with the CO2, remember this is controlled by the lungs, so controlled by respiration, this is what will be primarily altered in respiratory disorders. So back again, when you've got a metabolic acidosis, you expect your pH to be low. It is a metabolic process. So the primary alteration is in your bicarbonate, and your bicarbonate is low in metabolic acidosis. Okay, so how does your body compensate? Remember in this formula, in this equation, if that goes down, to maintain that one should also go down, right? That's just basic mathematics. So what happens with the lungs? If you've got an acidosis, a metabolic acidosis, the lungs try to help by blowing out more CO2, right? So the PCO2 also drops, and that tries to normalize your pH. So we would say that you're having a respiratory compensation to a metabolic acidosis. What happens with metabolic alkalosis? Too much bicarbonate within the system, so the pH goes up. It's in the alkalotic range, so it's above 7.45. How does your body compensate? Again, the lungs will check in and they will try to retain CO2, sawa, to just balance off that equation. What happens with respiratory disorders? With respiratory acidosis, we're saying the main thing is that you're retaining too much CO2, so your pH goes down, you become acidotic. So your kidneys will try to help you out, again, by taking the bicarbonate in the same direction, okay? So there's retention of bicarbonate, and that tries to get the pH back to normal. Finally, with a respiratory alkalosis, the person who's overventilating, so PCO2 is on the lower side, so the pH goes up, the body tries to kick in by also lowering that bicarbonate, okay? So this is basically both basic mathematics and also trying to figure out the physiologic principles behind it. So let's start off with metabolic acidosis. We've said the primary issue here is that you have got a bicarbonate deficit. So the blood concentration of bicarbonate drops below 22. So what are some of the things that can cause your bicarbonate to go down? Number one, you could be losing bicarbonate through diarrhea or renal dysfunction. So you've got proximal renal tubular dysfunction and you're not able to reabsorb bicarbonate. Two, it may be because of accumulation of acids. So you may have pathologic acids like lactic acid or ketones if you've got DKA. All these are acids that need to be buffered by the bicarbonate. Yeah. So as the bicarbonate is buffering these acids, the bicarbonate level goes down. Also, it may be because of a failure of the kidneys to excrete hydrogen ions in the distal nephron segments. Sawa. So these are some of the common causes of a metabolic acidosis. This is also the most common BGA abnormality you're going to see in the medical wards. So if you don't know too much about metabolic alkalosis, we'll forgive you. But metabolic acidosis, this you must know about because it is the most common abnormality you'll be looking at. So when we talk about a metabolic acidosis, it's further subclassified into either a high anion gap or a normal anion gap metabolic acidosis. So the high anion gap is usually abbreviated as a HAGMA. You'll hear that a lot in the ICUs, HAGMA. Or if it's a normal anion gap, it's called a NAGMA. So what exactly is the anion gap? So the anion gap basically is the difference between the cations and the anions. Remember, you are basically walking around your electron neutral because the positive charges should equal the negative charges. Sawa. So the anion gap is basically the difference between the cations, and the major cations extracellularly will be sodium and potassium, minus the major extracellular anions, and that is your bicarbonate and your chloride. Okay, so basically you're taking your sodium level plus your potassium, then you minus the anions, your bicarbonate and your chloride. So the normal is usually about 12 to 16. We'll see that this is if you've included the potassium, but there are some texts where they don't include the potassium because the potassium really is quite low compared to the sodium. So if you're excluding the potassium, then you'll see that the normal anion gap is between 8 and 12. So that's the one we more commonly use. But there are some textbooks that still give it as between 12 and 16, and this is because they've included potassium. So what exactly is this anion gap made of? So it's basically made of anions such as phosphate, sulfates, and negatively charged plasma proteins that you're not able to measure directly. Sawa. So you're not able, they're unmeasured anions. So they're the ones that are accounting for this anion gap between the positively charged and the measured negatively charged molecules. So when you've got an elevated anion gap, this usually indicates the presence of a pathologic acid, the things we're talking about, lactic acidosis or ketones, if you've got DKA. So this is just to emphasize the two ranges. Most of the time in our setup, we use 8 to 12 because you just take your sodium concentration and you minus your chloride and your bicarb. But like I've said, there's some books which will give you a range of 12 to 16, and this is because they've included the potassium. So you just need to say which one you're using if you're asked this question. Okay, sorry. So back to our anion gap. Sorry. We've said in the normal person, usually you'll have a normal anion gap of between 8 to 12 or 12 to 16. But then you can have a situation where you have got a normal anion gap metabolic acidosis, okay? So it is normal because it is still between 8 and 12, yet the bicarbonate is low. So you're having a metabolic acidosis because your bicarbonate is less than 22. You can see here it's 12. But you're still maintaining electron neutrality because your body compensates for that reduction in the negative charge by increasing your chloride compartment. Okay, so you can see the normal chloride here was about 104, but when this bicarbonate starts to go down, the chloride compartment can begin to expand, okay, just to maintain the electroneutrality. So that will be a normal anion gap metabolic acidosis. So metabolic acidosis because bicarb is low, but your unmeasured anions are not higher because your chloride compartment has expanded to maintain electron neutrality. But when you come to an elevated gap metabolic acidosis, when you calculate your anion gap, it's more than 12 or more than 16, depending on which formula you're using, because there is an addition of an unmeasured pathologic acid, which is negatively charged, okay? So this is where your things like your lactic acidosis are going to fall. It will be a high anion gap metabolic acidosis. So what are the etiologies of a high anion gap metabolic acidosis? Okay, I'm sorry, I don't know why this thing is refusing us to see our titles, or you guys are able to see the titles, I don't know. I'm trying to
yes,
remove
doctor,
it,
we can see
or you're able to see.
etiologies of
Okay.
an elevated gap acidosis.
Okay, sawa. So we've talked about pathologic acids. So where you've got uncontrolled diabetes or starvation, you can have an elevation in your ketones, which include acetoacetate and beta hydroxybutyrate. You can have elevation of lactic acid in any condition that leads to hypoxia. So hypoxia will lead to anaerobic metabolism and lactic acidosis, okay? Then you can also have other pathologic acids where you've got poisoning with some of the alcohols that we taught you last year. So ethylene glycol poisoning, methanol poisoning, all this leads to accumulation of pathologic acids within the body. So this one is lifted from your Davidson, so you can go and look at it in greater detail. But basically, one of the most common causes of a normal anion gap metabolic acidosis will be if you've got GI losses of bicarbonate, okay? And then with increased anion gap, we have all this accumulation of pathologic acids. So what are some of the symptoms of metabolic acidosis? You can get headache, nausea, vomiting, diarrhea, coma, and even death. So it's extremely important for you to be able to recognize a metabolic acidosis so that you can treat it before your patient progresses to coma and death. How does your body compensate for metabolic acidosis? Remember, you're acidotic, and this is arising primarily from a metabolic standpoint. So your lungs will check in, okay? So the lungs come in and they increase CO2 blowing off, okay? So there's increased ventilation. You're losing volatile acids through the lungs, that is your CO2, for you to be able to correct the pH back to normal. The kidneys also, if the metabolic acidosis is not because of a renal issue, the kidneys can also kick in and try to increase the excretion of hydrogen ions within the distal nephron. There's also some buffering that occurs between the cell and the extracellular fluid. So you've got too much hydrogen in the extracellular fluid. So your body tries to help out by getting the excess hydrogen into cells in exchange for potassium, okay? So hydrogen can move into cells and potassium move out of cells. So there can be a shift between the intracellular and extracellular compartments. Next, I move to respiratory acidosis. With respiratory acidosis, you're basically having carbonic acid excess caused by elevated levels of CO2 above 45. So basically anything that depresses your respiratory system, you're not able to blow off CO2, can lead to a respiratory acidosis. So this can either be because of chronic conditions like depression of the respiratory center in the brain that controls breathing, and this can be depressed by drugs or head trauma. if you've got paralysis of your respiratory or chest muscles or emphysema, okay? Acute conditions as well affecting the lungs like ARDS, pulmonary edema, pneumothorax, you're basically not able to breathe well. So you're retaining CO2 and therefore your partial pressure of CO2 goes up. You have excessive levels of carbonic acid and that reduces the pH. How do you compensate for that? The kidneys try to help by eliminating hydrogen ions in the distal segments and reabsorbing bicarbonate within the proximal tubular cells. So the signs and symptoms of respiratory acidosis: patient will be restless, they're lethargic, disoriented, you can have tremors, convulsions, and coma. And when you're examining the patient, you will note that their skin may be warm and flushed because of the vasodilatation that is caused by CO2 retention. How do you treat respiratory acidosis? Basically, there's an underlying problem in the lungs most of the time. So restore ventilation and treat the underlying pulmonary dysfunction, or if it is a head trauma, etc., treat the underlying cause. Alkalosis. With a metabolic alkalosis, now you have got a bicarbonate excess. So your bicarbonate is greater than 26. So this can be because of, number one, excessive vomiting, where you're losing your HCl, okay? It can be because of excessive use of alkaline drugs, certain diuretics, especially your loop diuretics and your thiazide diuretics can lead to a metabolic alkalosis, as well as severe dehydration that basically leads to a contraction alkalosis. So let's look at the mechanisms underlying alkalosis that may occur because of excessive vomiting. What are the mechanisms through which vomiting can cause metabolic alkalosis? So vomiting, number one, you've got loss of your acid, so loss of HCl, okay? So there isn't a lot of hydrogen ions to be buffered, therefore the bicarbonate concentration goes up, okay? That causes a metabolic alkalosis. Number two, and this is also very important, you can have loss of your sodium chloride leading to hypovolemia. And once you have got hypovolemia, you'll have increased reabsorption of sodium in the proximal tubules, so that you reabsorb sodium and also reabsorb water. But as you're reabsorbing the sodium, you also have increased bicarbonate reabsorption. So that will worsen your metabolic alkalosis. Another thing to remember is the renin-angiotensin-aldosterone system, which again will be activated by hypovolemia, okay? And what aldosterone does is that once you've got your hypovolemia, it tries to retain sodium and you lose potassium and hydrogen, okay? So there'll be this increased distal hydrogen secretion, and that now leads to increased excretion of hydrogen away from the body. So again, your bicarbonate goes up because there isn't a lot of hydrogen ions to be buffered. How do you compensate for a metabolic alkalosis? Like we said before, with a metabolic alkalosis, you would want now your lungs or your breathing to slow down so that you retain acid, okay? But then you can only slow down ventilation so much because hypoxia is going to limit that hypoventilation, okay? So compensation via the respiratory system is usually not very much for a metabolic alkalosis. The symptoms, respiration is usually shallow and slow. You can have hyperactive reflexes. You can also have arrhythmias, including atrial tachycardia. With metabolic alkalosis, especially if it's caused, for example, by vomiting, etc., what you want to do is to ensure that the volume status has been corrected. So usually we use sodium chloride or normal saline to try and correct the hypovolemic status. The last acid-base abnormality is respiratory alkalosis. So with the respiratory alkalosis, remember this is your patient who is hyperventilating. So they're blowing off CO2. So you've got a carbonic acid deficit. PCO2 is less than 35. And the primary cause is hyperventilation. So apart from anxiety, what are other conditions that can stimulate the respiratory center? Number one, if you've got oxygen deficiency at high altitudes. So mountain climbing, this is why you don't just wake up today and climb Mount Kenya. You just have to keep exercising and increasing your exercise tolerance to high altitude, okay? Number two, pulmonary diseases and congestive heart failure, because they cause hypoxia. Now hypoxia stimulates the respiratory center. Acute anxiety, fever, cirrhosis, and gram-negative sepsis have also all been shown to stimulate the respiratory center. So you blow off your CO2, and therefore you go into a respiratory alkalosis. How does your body compensate? You have got a respiratory alkalosis, so your CO2 is low, okay? So the kidneys try to compensate for that by conserving the acid so that your pH goes back to normal, okay? The kidney also tries to help by excreting the base, that is the bicarbonate, so that you get your pH back to normal. So the last part of my lecture is the approach to the interpretation of the BGA or the ABG, depending on which textbook you're reading, arterial blood gas or the blood gas analysis. So say you've been given a BGA in the ward, what are the steps to follow for you to be able to tell that this is a metabolic alkalosis with respiratory compensation, etc.? Number one, check the pH, okay? So is the patient acidotic? So the pH will be less than 7.35. Or is the patient alkalotic? The pH will be more than 7.45, okay? Next, look at the PCO2, okay? So just do it in steps and in these particular steps. Next, look at the PCO2, okay? So if your patient, let's go through this pathway. If your patient is acidotic, you've seen the pH is less than 7.35 and the CO2 is high. This is in keeping with a respiratory acidosis, okay? If your patient is alkalotic, next thing you look at is the CO2, and the CO2 is low, okay? So they're blowing off CO2, so you're blowing off acid, so you're going into alkalosis. You will call that a respiratory alkalosis. Sawa sawa. After that, you move on to check the bicarbonate, okay? So for example, if you see that your patient has got a pH that is less than 7.35, you check the CO2 and the CO2 is normal, okay? You next look at the bicarbonate and you find that the bicarbonate is low. You will now call that a metabolic acidosis, okay? So the bicarbonate is low in keeping with an acidosis. Finally, you want to check for any compensation. So what do we mean by compensation? So let's go again through this pathway. You found that your pH is less than 7.35. You look at the CO2. The CO2 is not high, okay? So it's not a respiratory acidosis. The CO2 is not normal. You actually find that the CO2 is low, okay? You don't expect the CO2 to be low in acidosis. So the primary issue is not a respiratory component, okay? So you go again to your bicarbonate, you get your bicarbonate is low, so you say for sure this is a metabolic acidosis. But why is the CO2 low? Why is the CO2 not in keeping with the pH? So the CO2 is not in keeping with the pH because it is a compensatory mechanism. Sawa sawa. So let's do some examples to make this a bit clearer. So I'll do the first example, then I'll ask for 2 volunteers to do the next 2. Khan, you'll probably be the first one because you're able to unmute yourself. So prepare. So example number 1, you get your BGA and the pH is 7.31. So immediately you recognize that this is less than 7.35. Therefore, this is acidosis. So you already get 1 mark for that. Next, you look at the PCO2. Now, with an acidosis, if it is respiratory, you expect the PCO2 to be high. Okay, so you look at your PCO2 and it is 40. So you quickly remember that normal PCO2 is between 35 and 45. Okay, so the PCO2 is normal. Therefore, this acidosis that we are seeing is not because of a respiratory issue. It is not because of retention of CO2. Okay, so you tick that, you mark that as an X. It's not respiratory. So you move on to your bicarbonate. Okay, quickly you remember that normal bicarbonate is between 22 and 26. This bicarbonate is low. Is low bicarbonate in keeping with an acidosis? Indeed it is, okay? So you conclude that this is a metabolic acidosis, okay? And there's no compensation. Because CO2 is not trying to compensate for that acidotic pH. Taimur, are you ready? Are you still with us? So you have dropped off?
Yes, doctor, I'm here.
Excellent. So take us through example number 2.
So the pH is 7.49, which is more than 7.45. So that is already a alkalosis.
Excellent. 1 mark.
PCO2 is 22 millimeters of mercury, which is below the normal range. So this is a respiratory disturbance, disorder. And bicarbonate is 25 millimeter mercury, and the normal is 22 to 26. So that is within the normal range. So I think this is a respiratory alkalosis.
Excellent. Yeah. It would be a respiratory alkalosis because your pH is more than 7.45. Okay. And when you look at the CO2 is low. Yeah. Remember, your CO2 is representing your acids. So your CO2 is low. So this is a respiratory alkalosis. So you're exactly right. And there's no compensation. Senor?
Yes, doctor.
Yeah, because your bicarbonate is within the normal
range.
Okay. Okay. Do you have a volunteer for the third one?
Yes, I have permitted them to unmute, so anyone can unmute.
Excellent. Anyone who would like to try the third one before I show you?
Hello.
Excellent. This is who?
Zipporah.
Hi, Zipporah.
Hi.
Thank you for volunteering. So there we go.
So the pH is 7.33, which falls below the range. That means there's an acidosis.
Excellent.
The PCO2 is also 20 millimeters of mercury, which the normal range we said is 35 to 45. So the PCO2 is low. The bicarbonate
is that, sorry, before you move, is that in keeping with a respiratory acidosis?
Yes. No. It
No,
should
right?
have been higher.
It
yes,
should be higher than 45 if it was a respiratory acidosis, correct?
Then the bicarbonate is 19 and our range is 22 to 26. So it's low, which is together with alkalosis, that's still really low.
A low bicarb would be in keeping with acidosis or alkalosis?
Sorry, alkalosis.
Acidosis or alkalosis?
Acidosis.
Acidosis, right? For you to be alkalotic, you need to have been retaining the bicarb, yeah? It's a base, When you have a high base is when you become alkalotic, yeah? So when this is low, when the bicarb is low, it means you're having an acidosis. Probably some of the bicarb has been used up to buffer some excessive acids. Sawa. Yeah, that makes sense to you?
Yes, it does.
Okay, good. So we've established that the bicarbonate is low, and that is in keeping with acidosis that we had seen in the pH. So would you call this a metabolic or a respiratory acidosis?
A metabolic.
Excellent.
Acidosis.
Excellent. So it's a metabolic acidosis. Was there any compensation or not from the lungs?
It looks like there was compensation because the PCO2 is low.
Exactly. Yeah. So the body is trying to compensate by blowing out CO2, blowing out volatile acid so that you get your pH out of the acidotic range. The final thing is the compensation partial or complete.
It's partial.
Excellent. Because
if it was complete, it would have gone back to the normal range. But it's
excellent.
still out of the normal range.
Asante sana. I can sleep in peace that someone got it. Thank you. Any questions? Now that you're unmuted, you can just, now that you have the powers to speak, you can just unmute and ask. I know it's a lot. I've tried to simplify it. You can please go on and read more. You can look up YouTube, what are they called? Videos on YouTube on acid-base imbalances, for example, from Strong Medicine. He makes it very easy. And do a lot of practice questions even from the net on interpretation of the BGA.
Doctor, there are 2 questions in the chat box. May I read them to you?
Okay.
What happens to PCO2 and PO2 if the patient has pulmonary edema and or paralysis of muscles of ventilation?
Okay. So with that, you'll have both retention of CO2, and then also because you're not ventilating well, your PO2 will also be low. So you'll have both hypoxia and you're also hypercapnic, okay? And that is basically the classic definition of someone who's going into respiratory failure, okay? So you expect them, because they're retaining CO2, to have a respiratory acidosis.
Okay. The other question is, kindly go over the slide for compensations for respiratory alkalosis.
Okay, so let me share my screen again. So this summarizes everything. So he wants me to go through respiratory alkalosis.
Yes, doctor.
Respiratory alkalosis. Okay. So with respiratory alkalosis, always remember, this is the patient who is hyperventilating. Okay. So their CO2 goes down because they're blowing off CO2 with every breath. They're ventilating so fast, they're just blowing off CO2, CO2, CO2. Okay. So because you're losing volatile acid, that means you become alkalotic. So your pH goes up. Okay, so how do you compensate for that? We've said again, this is again from just basic principles from math. If that goes down, you also want your bicarb to go down. Okay, so how can you reduce your bicarbonate? Remember, bicarbonate is mainly being reabsorbed by the kidneys. Okay, so the kidneys will reduce the reabsorption of your bicarb. That will be the primary mechanism. I hope that makes sense.
Yes, doctor.
Okay.
There are a few more questions. Melanie is asking, in clinical chemistry,
yes,
we were told that pulmonary edema and pulmonary thromboembolism leads to respiratory alkalosis. Could you kindly explain how that occurs?
Pulmonary edema causing a respiratory alkalosis. Well, yes, unless you have got a patient, you see, also you can have a very anxious patient. You know, when you're in pulmonary edema, you're suffocating. Eh? You can imagine your lungs are full of fluids. Sawa sawa. So if you're suffocating, basically, you start becoming very anxious. And this is also what happens even with patients with cardiac failure, for example. They're very anxious. Patients with MIs, very anxious. They're in cardiac failure, and they're also suffocating because of too much fluid in the lung. So it would be correct to say that you can actually have both types, because you're not able to ventilate very well, you'll have CO2 retention, okay, in one situation. But if you're also adding anxiety to that mix and the patient is hyperventilating, I guess that's how you'll be able to explain now a respiratory alkalosis. But this is much less common than a respiratory acidosis, okay, because of retention of CO2. But if you've got both a lung pathology plus excessive anxiety with excessive ventilation, then you can blow out too much CO2 and go into alkalosis. But I still maintain the more common abnormality will be a resp acidosis.
Wambui is also asking, how will a patient with CKD compensate if they happen to develop respiratory acidosis?
Yes, that's why we said for that particular person, if your kidneys are not working well, you're not going to be able to compensate. So you need a working kidney for you to be able to compensate for a respiratory acidosis, okay? So back to our slide, if you've got a respiratory acidosis, the primary pathology is that you're retaining CO2, okay? So for you to normalize your pH, you also need to retain your bicarb. So with a working functional kidney, you're going to increase reabsorption of bicarb. If your kidney is not working, however, you are in trouble, okay? So basically you won't be able to compensate. The body will not be able to compensate. So it is you, the doctor, now to come in and externally help by managing the primary lung pathology so that they stop retaining CO2.
Dan is also asking if you can please go over the acid-base disturbances in aspirin overdose.
Acid-base disturbances in aspirin overdose. That is another 1 hour lecture, right? That we taught you in last year in pharmacology, okay?
Yeah.
But basically, I can share again with you my slides for salicylate poisoning. Sawa. So I'll do that, okay? But basically with salicylate poisoning, again, it's a weak acid, so you go into acidosis. And so one of the main things that you need when you're managing a patient with salicylate poisoning is that you need to alkalinize their urine so that you're trapping that salicylate within the urine, okay? So when you alkalinize the urine, there's what we call the phenomenon of ion trapping, sawa. So the alkalinized urine plus the salicylate, which is a weak acid, it now becomes ionized. It's not able to be reabsorbed back into the body. So you're able to excrete the salicylate, sawa. That was a take-home message from salicylate poisoning, sawa, that you can actually manage it by looking at the ion trapping phenomenon.
Okay. There are more questions.
Okay.
Lydia is asking, how does liver cirrhosis cause respiratory alkalosis?
How does liver cirrhosis cause respiratory alkalosis? Okay, your patient with liver cirrhosis, one of the things that can happen is that you go into liver failure. So you have your hypoalbuminemia, you've got your ascites. And what happens with ascites is that you can have splinting of the diaphragm. Sawa. So massive ascites can lead to splinting of the diaphragm. Therefore, you're not able to breathe well. Yeah, so that causes hypoventilation. Sawa. So ideally, with hypoventilation, you should actually be retaining CO2 again. So that one, you check it up and tell me. But that's what I can think of for now. Liver cirrhosis, splinting of the diaphragm with excessive ascites, and then you get hypoventilation. But that should give you CO2 retention.
Bramwell is asking, in a worsening case of metabolic acidosis, will the body choose to correct the worsening hyperkalemia or focus on correcting the acidosis via exchanging potassium with hydrogen ions?
Okay, so that's a good question, because the immediate threat right now is the excessive hydrogen ions within the extracellular fluid. So the body will compensate by taking in hydrogen ions and releasing potassium, okay? But most of the time, it's not that this potassium is now going to go into the arrhythmogenic range. It's not going to go into 6.5 etc. Because remember, if your kidneys are still functioning, that excessive potassium that has shifted from the intracellular space is going to be excreted by the kidneys, okay? So you don't really expect with functional kidneys, you don't really expect there to be very deranged hyperkalemia.
Okay.
Hey, okay, Taimur.
Too many questions.
Allow me to
Yes.
breathe now and have a nice lunch. I'll send you the slides immediately.
No problem, Doctor. My
Okay.
gratitude to you for your time and answering all the questions.
Okay. The ones I could. Thank you so much,
Yes.
guys. Have a nice day.
I wish you a
Okay.
blessed day ahead. Thanks.